So the title of this talk is Advances in Glaucoma Therapy, but the focus is on minimally invasive glaucoma surgical techniques. So how many of you have done angle surgery? So I think this topic is going to be brand new for most of the people here and most of the people listening in. We talked a lot over the last 2 days about the treatment algorithm, how we think about treating the glaucoma patient in sequence. This is a concept that is radically changing over the last 15, 20 years or so. And like I said earlier, there is no algorithm that says you always have to start with drops, then go to laser, and then go to surgery. But traditionally speaking, this is the way we used to think, from drops to filtration surgery, and then end stage, we would use cyclophotocoagulation. But now we have so many different devices that we can use that were not available just 20 years ago. So when I was in training, we had basically just this side of the decision tree. So medications and laser would fail, and I would say, okay, it's either a trabeculectomy or a glaucoma drainage device. But now I can start thinking about the different MIGS devices and the more minimally invasive drainage devices like a Zen. And what you're seeing here on this slide is not complete because we keep getting new devices every couple of months or every 6 months or so. There's something new. So let's talk about the concept of minimally invasive glaucoma surgery. Think of these factors when you're thinking about what MIGS might be. When we say MIGS, we're talking about a low touch or minimally invasive approach to glaucoma surgery. We want it to have at least modest efficacy. It should have an extremely high safety profile, similar to phacoemulsification, and it should have rapid recovery, similar to what we experience with cataract surgery. So most of this talk is going to be about adding MIGS to your repertoire, to your practice, but I'll also cover the technique of how to start getting into it from a practical standpoint. So we'll talk about patient selection. We'll talk about the day of surgery, what to expect, and then some of the follow-up pearls for each of the specific devices. Now, this slide is the way that I started thinking about MIGS procedures and how to apply it to my patients. So if we're looking at traditional filtration surgery, high risk, but also great IOP lowering. And that's why the trab and glaucoma drainage devices live in this category. Typically, we think of MIGS procedures being less of the IOP lowering, but less risk. And for that reason, we would traditionally think of MIGS procedures being applied to only mild to moderate glaucoma. I don't think you should think of it that way. I think you should think of MIGS applying to many different patient populations. And I'll show some clinical results to show why I'm saying that. Generally speaking, when thinking about the preoperative phase, you're thinking about how to get the patient ready. What should you do? The consenting process. And one pearl that I would ask you to always keep in mind is if you're combining with phacoemulsification, to always say plus or minus MIGS. Sometimes you go in and you do the cataract surgery and you can't do the MIGS procedure for any number of reasons. Maybe there's a complication during the cataract surgery and you don't want to do the MIGS. Or maybe you don't have great visualization and you can't do the MIGS implant. So you just want the patient to be aware that you may or may not do the MIGS, that you're consenting for it, but it may not happen. So you also want to discuss the recovery process with the patient and that it's not exactly the same as just doing phacoemulsification. The reason for that is they might have a friend or a family member who had cataract surgery, and that friend or family member didn't have to do all the things that they're doing when they had combined phaco-MIGS. So the drops that are used preoperatively, the dilation drops, everything is pretty standard, similar to phacoemulsification alone. And this last point about discussing the positioning with the patient before the surgery is extremely important. So when you do a MIGS procedure, you typically move the patient's head away from the surgeon and you tilt the microscope towards the surgeon. This is so you can do gonioscopy and visualize the angle. If you don't tell the patient to expect that movement of both the head and the scope, they're going to be worried about what's happening during surgery. Why am I being repositioned? Why am I hearing the nurses moving the microscope? So I tell the patient before the surgery to expect this, and then I tell them while I'm doing the repositioning, remember, we talked about this. This is expected. Now, if it's a standalone, not combined with phacoemulsification, instead of dilating, we typically give a drop of pilocarpine to constrict the pupil. This allows you to protect the lens if the patient is phakic, and it also gives you better visualization of the angle when you deepen with viscoelastic. So here are some pearls for the intraoperative phase of doing your first MIGS procedures. Whenever possible, use a meiotic so that you can get a better view of the angle. Even if you've dilated for phacoemulsification, you can inject myostat at the end of that before you do your angle procedure. Start off with very routine cases, not the difficult cases. It would be nice, if possible, to use peribulbar anesthesia so that the eye is also cooperative with you when you're doing the procedure. And remember these two last points: to hydrate the wounds very well and to leave the pressure in the eye after injecting your BSS at the end of the case high, around 25 millimeters of mercury.
За тэгэхээр мэдслийн төгсгөлд болохоор BSS буюу шингэнэ хийснийхаа дараа нүдний дотоод аралтыг нэлээд өндөр буюу 25 дээр үлдэх хэрэгтэй.
The reason for this is most MIGS devices open up the trabecular meshwork. And if you don't hydrate the wounds and you allow the chamber to go low and the pressure to go low, you get blood reflux into the anterior chamber. There are multiple other considerations that you should keep in mind intraoperatively when you're doing MIGS. And if you think about it, just think about the differences between doing MIGS versus doing traditional phacoemulsification. So when you're doing cataract surgery, typically we have our elbows at our sides. We're very comfortable in that position because most of us are doing a lot of phaco and we're very comfortable with that position. If you take a surgeon who's been doing phaco for 10 years and you say, now extend your hand, which is what you need to do when you're doing gonioscopy, that positioning change can throw a surgeon off and it should be practiced. Or something as simple as operating with both of your hands having instruments inside of the eye versus only one inside of the eye and the other one outside of the eye. So instead of your hands working in the same area, now one hand is working outside of the eye, one hand is working inside the eye, and we tend to forget about the hand that's working outside of the eye. This is when the surgeon tends to press very hard with the gonio lens on the cornea because they're not thinking about the hand that's on the outside. And when that happens, you cause corneal stria and you can't see the angle very well and you're already uncomfortable. So you push harder on the cornea and that's a cycle that continues. The other side to this is the space that you're working in. With cataract, you have multiple millimeters of space that you're working in. With MIGS procedures, you're working within a 1 millimeter space. So if you have a slight tremor, it becomes much more obvious. And you also have to make slower, more deliberate movements so that you don't hit the cornea or the iris. This is my friend Shakil Sharif showing us what the differences are between the positioning for phaco versus the positioning for MIGS. This lecture will be online, so you can get the link at the bottom here. And if you go to that, there's a good story about the differences on positioning MIGS versus phaco. So I think you can see the subtle differences. Phaco with the straight back, elbows at the side, both hands over the eye. Versus with MIGS, you have one arm that's straightened and you're working further away from the head and the eye. You're also working with instruments that could potentially touch the bottom of the microscope if you're not careful. So the message here is you should practice this in the operating room before you do your first cases. We do not traditionally do gonioscopy during surgery. This is very clear for most surgeons around the world. So when you're first thinking about doing MIGS, I think it's important to practice intraoperative gonioscopy in the operating room, maybe at the end or before you do your phacoemulsification. One of my favorite pearls about doing gonioscopy is to put the viscoelastic on the bottom of the lens instead of on the cornea itself. The reason for this is when you then put the gonio lens and viscoelastic on the cornea, it'll displace any heme, any blood that might be on the cornea. You don't have any entrapped bubbles in between the viscoelastic and the lens. And you also tend to use less viscoelastic when you do it this way. Remember to rest your hands on the forehead or the zygoma so that your hand is steady. When you're working in a 1 millimeter space, everybody has a tremor. So stabilize your hands as much as possible. There's also a tendency with the hand that's holding the gonioscope to want to direct the eye. So if you can't see perfectly, you try to move the eye away to actually get a better angle into the trabecular meshwork. That doesn't work. You just create more corneal stria when you do that. So get used to positioning the head correctly and telling the patient to look towards their nose on that side. You also want to zoom into your view much more than you would for traditional phacoemulsification. This is the view that you want, about this magnification when you're doing angle surgery. So when you're doing cataract surgery, when you're training others to do cataract surgery, you always say that you want to see a little bit of the white on either side of the cornea at least. You don't want to focus all the way in on the iris. But when you're doing the MIGS procedure, you don't follow that rule. You really want to zoom into the view on your gonio lens. So this video makes a very simple point, and you're just going to see it playing on loop here. So what I'm showing here is the concept of practicing before you do your first case. So at the end of cataract surgery, for your next 10 cataract surgeries, position the patient in the microscope and then do the movement of most MIGS procedures in the angle with one of your choppers, let's say. If you do this, it'll accomplish a few things, including making the surgeon more comfortable, but it also makes your operating room team more comfortable with everything that has to happen for MIGS. Let's talk about wound construction. So when we're teaching phacoemulsification and making your main wound, oftentimes we talk about just touching the limbal vessels so that you get a little bit of oozing when you go in and do your wound, just to enhance closure of the wound afterwards. You don't want to do that with MIGS procedures because that oozing blood will make its way into the viscoelastic and obscure your view. So we make sure we go a little bit more anterior and we don't touch the perilimbal vessels. There's also a common question of when should I do the MIGS procedure? Should I do it before the phacoemulsification or should I do it after the phacoemulsification when they're combined? We didn't have a good way of answering that, so we did a study where we looked at images of the angle before and after cataract surgery. And we found that there is no difference in the view before or after in most cases, overwhelmingly in most cases. So you should do what's most comfortable for you. I know surgeons who always do it before and surgeons who always do it after the phacoemulsification. It's really up to you. So this is a video of putting everything together. This is a video of a goniotomy. I believe this is the surgeon's first use of KDB. So take a look and just see him putting it all together. This is John Berdahl in South Dakota. So he goes in with KDB. You could see he could probably zoom in a little bit more. And he does the outside in technique of excising the trabecular meshwork. So one thing I want to point out, if you stop around here, you can see some stria in the cornea. John is one of the most experienced angle surgeons in the world, so he can get by doing this. But it's something you want to keep in mind when you're doing your cases. How was your view and how can you improve and push less on the cornea? So at the end of this case, you have a strip of trabecular meshwork that's right on top of the iris. And you see him pull out the strip from the anterior chamber. Now the surgery is done. Post-operatively, what do? You treat very similar to cataract patients when it's standalone cataract. Use your standard antibiotic, steroid, non-steroidal. In most cases, with the MIGS that I do, I start the patient back on one of their glaucoma drops. And the reason that I do that is I want them on a glaucoma medication when they're taking their steroids post-operatively. We know that post-MIGS patients can still get steroid response glaucoma, steroid response ocular hypertension. Their pressure can go up. Once they're off their steroid post-operatively, I always try to remember to take that glaucoma drop off as well. After all, the goal of MIGS surgery is to get the pressure down, but also to decrease their dependence on medication. And then you can restart the medications as needed, depending on what the pressure is. So let's talk a little bit more about excisional goniotomy. And I want to talk a little bit about how we developed KDB to give you an idea of that road that we took. So traditionally speaking, we used to think of goniotomy as incisional goniotomy, doing a single cut in the trabecular meshwork. How many of you have heard of Otto Barkan? So probably the most famous ophthalmologist of his time in the 1930s, right? It's been a little while. So he performed goniotomies in both children and adults. And in his second or third paper on the results, he said, do it in children, but it does not work in adults. So for 60 years after that, ophthalmologists did not do goniotomy in adult patients. It turns out Dr. Barkan was not right about that. So in around 2011, 2012, I was working in the laboratory and I was doing imaging studies on trabecular meshwork. And I needed to get strips of trabecular meshwork in order to do the advanced imaging we were doing in the laboratory. If any of you have worked with trabecular meshwork, it behaves very much like wet tissue paper. It's very hard to strip and to collect and leave it as one single strip. So I started working on a design that would allow me to do that, to harvest tissue, to do the imaging studies that we were doing. And this is the basic device that we came up with a sharp tip that allows you to get into the trabecular meshwork and into the canal, a ramp that would then elevate the trabecular meshwork and put it on stretch. And then instead of doing the incisional goniotomy, we performed an excisional goniotomy by doing 2 parallel incisions on the trabecular meshwork.
хэрэгтэй.
Now, it turns out the toughest part of that was creating the ramp at the proper angle. So after multiple iterations, we got the right angle and we started routinely getting strips of trabecular meshwork. Our lab group was very happy because they were getting tissue very easily compared to what we were doing before. And it wasn't until after that that I said, maybe we can use this for surgery. So it was a case of taking something from the laboratory and then taking it into patient care that improved patient care. So we did some initial histology studies comparing incisional versus excisional goniotomy. And just to prove that you can remove the majority of the trabecular meshwork by doing the excisional goniotomy. It turns out, in our experience, the reason why incisional goniotomy was failing in adults was because of reapproximation of the leaflets of the trabecular meshwork. And when you excise a big strip of trabecular meshwork, there was nothing to reapproximate. It could not reconnect. So we made this device, put it on the market, and you can see this is Paul Singh doing one of his first procedures. Again, the outside in technique. The strip you can actually see connected and stays on the tip of the KDB. See it there? So oftentimes you don't have to pull it out with forceps. It just connects to the KDB and you take the KDB out. One thing I tell patients is that at the end of the case, we test for flow to see what the effect is of the MIGS device. And what you're seeing in this video is the episcleral vessel fluid wave. What I want you to do is to focus on this area of the sclera. And we're injecting BSS into the anterior chamber. And I want you to look at this area again right here. Do you see the blanching of the vessels, right? So what that tells me is the procedure that we did was successful in unroofing the trabecular meshwork and that the collector channels are open. And this patient has a good chance of decreasing their intraocular pressure. This is not 100%. Sometimes you don't see this and the patient still has low pressure. Sometimes you see it and the patient still has high pressure. It's just a good indication that at least your treatment was successful on the table. So who's a good candidate for goniotomy? Especially for your first few cases, you need a very cooperative patient with clear anatomy. Preferably a patient with pigmentation on the trabecular meshwork so you can see it clearly during surgery. It can be any stage of glaucoma from mild to severe. And sometimes you can use trypan blue in order to stain the trabecular meshwork so you can see it better. That technique is very similar to using trypan blue to stain the capsule for cataract surgery. Relative contraindications for goniotomy include patients with active neovascular glaucoma, active uveitic glaucoma, elevated episcleral venous pressure like Sturge-Weber, poor view of the angle if you can't see very well, and if you have a goal pressure that is very low, 12, 10, you're not going to get that with MIGS. So what can surgeons do to optimize visualization prior to surgery? Make sure you take a look at the angle before you go to the operating room. That's really the number one rule, is to practice your gonioscopy over and over in the clinic so that you get used to the anatomy and you do it on the patient before you do their MIGS in the operating. So post-operative and the follow-up pearls, very similar to what I mentioned for the other procedures. So I'm not going to go over the clinical data in great detail. One of the big knocks, one of the big negatives on goniotomy when we first started using KDB was that we don't have a lot of data. So that wasn't just KDB, it was all MIGS. We just said, hey, there's not a lot of data, so how can you actually decide what to do? So we started doing studies in order to overcome that limitation. Here's one of the first publications looking at standalone goniotomy 6-month results in a subset of patients who were high, medium, and lower pressure preoperatively. And what I like about this study is it shows that no matter what the starting pressure is, you can still get them down to a manageable pressure after the procedure. So don't use the preoperative pressure as the only guide to what procedure you can do, because you can get the pressure significantly lower with just a MIGS device. We also have long-term data to show that up to 30 months, actually just 2 days ago, same doctor published his 72-month results on the same patient cohort with sustained efficacy. So it does last for a long time. We looked at our own results at the University of Colorado, both standalone as well as combined with phaco. but also across mild, moderate, and severe disease. And we found significant IOP lowering across the board for all of these patients. You see a lot of angle closure glaucoma in Mongolia. And we find that doing goniotomy is probably one of the most effective things you can do to lower pressure in those patients. We also did a study looking at uveitic patients who were quiet, so their uveitis had been treated. They were also super responders to doing goniotomy. One of the things that we lack in MIGS surgery is head-to-head clinical trials. So we did a study where we compared iStent versus KDB. This was prospective and multi-center, and we followed the patients for a year. And what we found was the intraocular pressure lowering was similar, and the medication reduction was similar. But goniotomy was slightly more effective at both lowering pressure and decreasing dependence on medication. So this is just a summary of the publications. There are 110 publications on excisional goniotomy now. So we've come a long way from having no studies to having one of the most studied procedures right now in ophthalmology. And this is usually the first MIGS procedure that we train our residents and fellows on. It's relatively straightforward to do. So one of the fun things that happened with KDB is the journey that it took from the lab to the operating room. And what we're doing now is we're actually going back from the operating room to the lab. So now we're taking the strips of trabecular meshwork from the operating room and we're taking those back to the laboratory to study them. And we're finding things that we never knew about glaucoma because we never looked at the tissue in this way. This is an interesting case that was sent to me from doctors in Dallas who performed an incisional goniotomy on trabecular meshwork. The tissue had reapproximated after the incisional goniotomy. They then performed a KDB goniotomy with excision of the tissue. They sent it to my lab for analysis to take a look at the tissue and what it looked like. And what we found was something that we had not seen before with the scarring of the tissue. All of this is scar tissue along the trabecular meshwork. So this was a patient that I had inserted a first generation iStent on a couple of years before this video. The pressure had gone back up and the patient was back on medications. And when I did gonioscopy in clinic, I could see that the iStent was displaced towards the iris. So we made the decision to go in and remove the iStent and perform an excisional goniotomy. And I just want you to see what we found when we were doing the procedure. So start off by removing the iStent. See how easy it is to remove the iStent? It was really just hanging on by a thread. So now I'm doing an excisional goniotomy from right to left, and it feels different to me. Usually you don't feel so much resistance when you're doing an excisional goniotomy. And as I was going from left to right, I started seeing a layer of tissue, a membrane that was not seen initially on gonioscopy. And that film was actually producing some resistance to my excision. In fact, it was both fibrotic and slightly vascular. You can see here, this is the outline of that membrane. So at this stage, I had done dozens of iStents and the patients were coming back in because everything has an expiration period when you're doing glaucoma surgery. And we started doing this on all of our patients who were coming in with failed iStent, and we found the same thing over and over again, fibrosis and scarring of the trabecular meshwork. So you can see multiple samples that we published in Journal of Glaucoma of samples that showed scarring after removing the iStent and removing the trabecular meshwork. We have seen this with every single trabecular meshwork excision that we've done in both iStent and hydrous implantations. So very similar to the scarring that happens around an Ahmed valve or a Barvelt with the encapsulation of the bleb, the same type of scarring happens when a foreign body is in the trabecular meshwork. And if you don't have full excision of the trabecular meshwork, you can see it even with goniotomy, especially incisional goniotomy.
So thank you, Dr. Kahook. The first question is from Dr. Morteza. Is it possible to do goniotomy from superior surgical position? So we'll also translate here into Mongolian, but the question is is it possible to do a goniotomy from superior surgical position?
So very good question. And it's a question that came up when MIGS was first introduced. There are some surgeons who do all of their surgery sitting superiorly. For those surgeons, when they started doing MIGS, they asked the same question. And it turns out with a slight change in your positioning, you can do the MIGS procedure superiorly. If you have a very elevated brow, then I would recommend not trying to fight against the anatomy and just move temporally.
Do you recommend air injection after goniotomy?
You can do that, and some surgeons believe that decreases reflux, and we don't do that. The rules that we follow are what I mentioned earlier with hydration of the wounds and leaving the pressure at a slightly higher IOP.
So 2 questions. How long do you give steroids after goniotomy? How do you manage intraoperative bleeding?
So steroid use is very easy to think of. It's exactly what you would do for phaco emulsification. In rare cases, you might have extended inflammation and you would just treat appropriately with a longer course of steroid. That would be more likely with something like endocyclophotocoagulation rather than a traditional MIGS procedure. So I would ask you to think of the postoperative drops as exactly what you would do for cataract surgery in the overwhelming majority of patients. For intraoperative reflux, and that's an important concept, so it's intraoperative reflux of blood into the anterior chamber. Don't think about cauterizing or tying off a vessel or treating a vessel because this is a different mechanism. When you're opening up the trabecular meshwork and the pressure in the anterior chamber is lower than the episcleral venous pressure, blood comes into the anterior chamber. The best possible thing to do is to increase the pressure in the anterior chamber. You can do this with BSS, with balanced salt solution, or a little bit of viscoelastic, and then sit back in your chair and wait. That's actually the solution for a lot of things that happen in the operating room. A lot of times we're trying to do a lot of things in a row and we're not giving the eye time to do what it usually does, which is it takes care of itself. So if I'm getting a lot of reflux, I increase the anterior chamber pressure with BSS. I might hydrate the wounds and then I sit back, I move the scope light, make sure that the cornea is well protected with viscoelastic, and we just give the eye a few seconds to stabilize. One last point about this is at the end of surgery, if you're more worried about reflux, you can inject a dispersive viscoelastic in the angle. So something like Viscoat. And you would take at the end of the case, the cannula and go all the way up to the angle that was treated. And you inject a little bit of Viscoat until you see it coming onto the iris body. That tends to plug up the collector channels in the early postoperative phase. Do not use cohesive viscoelastic for this. That can stick around for a long time and cause spikes in pressure. So let's talk about, hey, you're ready to do angle surgery. Which one should you do? That's the big question, because remember that decision tree, we have 20, 25 devices that we can use. So when I was trained to do cataract surgery, we had really 1 or 2 options for lenses, monofocal and the beginning of toric lenses for implantation. Soon after that, we started getting the multifocal lenses and the enhanced depth of focus lenses that are seen as more novel. We started getting more options. And the beauty of that is we could take the best lens for the right patient and match that to the best possible outcomes for each patient. But for glaucoma, we weren't doing that. We were just giving them either drops, laser, or some type of filtration type procedure. And now that we have all of these MIGS procedures, we can start doing for glaucoma what intraocular lenses do for cataract patients. So if I were a trainee today and I was looking at all of these different options, I'd get very excited about treating glaucoma. So our patients want the best outcome possible, and they want something that's very safe. And the surgeons want something that's safe and predictable and to best treat the patient. So here's a patient case, 65-year-old with primary open-angle glaucoma. Pressure of 15 right eye is the goal, but the pressure today is 18, and the patient has a visually significant cataract. No prior surgery and is currently on latanoprost. The visual field shows an early nasal step that is slowly progressing. And the question is, what's your next step? So we have a menu of various different devices that we can use when we're combining it with phaco emulsification. And you see that partially listed on this right-hand side. All of these choices can actually lead to confusion, not knowing which one to use. And we used to think that we had many devices, but no real evidence-based medicine to drive our decision-making, no real data. And I think that's no longer true. I think we have plenty of data to help us tailor the therapy, individual MIGS devices to individual patients. So let's just take a deeper look on how I make my decisions with the different MIGS procedures. So you can look at it from the mechanism of action. There is the traditional conventional pathway. There's the uveoscleral outflow pathway. And really for MIGS, that is properly defined as the suprachoroidal outflow because it's going through the suprachoroidal space. And then there's a small bucket of others. So as I'm talking through this slide, what you're going to see in this video is implantation of a Hydrus stent. The Hydrus was made by a company called Ivantis that was acquired by Alcon. So Alcon is selling Hydrus now, and you might see this popping up a little bit more around the world. And I'll talk about Hydrus in a second here, but conventional pathway is usually my first choice. The reason for that is it is the most safe, it's the most physiologic, and it leaves a very small footprint in the angle. The approaches that fit into this category include inserts, implants like the iStent and the Hydrus. And goniotomy also fits into this category. We all have our biases from our experiences, but we also look for data to help drive our decision making. In my hands, from what I've seen, I'd rather not place a device in the angle if I don't have to. So for example, the Hydrus implantation that you're seeing right now is 8 millimeters long. And I know that doing a goniotomy is as effective, if not more effective, and it doesn't leave a device in the angle. I think we always like to talk about our disclosures. I think everybody's aware of my disclosures during this lecture. So I have a very big bias towards goniotomy. But what I will say to you is you should pick one of these approaches, whether it's iStent, Hydrus, goniotomy, and more recently, the introduction of canaloplasty, and pick one of those that you can get really good at in the operating room. So I use goniotomy for mild to severe, standalone, or combined. And where we're headed in the future is to access multiple collector channels and to combine different procedures. And also to be able to do these procedures potentially in office and not have to go to the operating room. That would be a big deal for our patients. So the next category is the unconventional pathway. Really think of this as suprachoroidal pathway. This is not my first choice because it's not very predictable. It has also traditionally been associated with more complications. The main device that was on the market was called CyPass. And this is a CyPass implantation that you see in the video here. Basically a tube that goes into the suprachoroidal space through the angle abutting the scleral spur, and it sits in the suprachoroidal space. Unfortunately, this device was associated with significant corneal endothelial cell loss. It was pulled from the market, so it's no longer available. Companies are looking at different materials and different techniques to see if they can bring another device that does a similar thing to the market, but none of them have really made it to the market quite yet. So now we're going to talk a little bit about full thickness procedures. The big goal for MIGS procedures was to avoid a bleb. The Zen device is a minimally invasive glaucoma drainage device that is definitely still associated with a bleb. You can insert this device either ab interno or ab externo. And this is an example of ab externo placement of a Zen stent. The reason that this isn't my first choice is I've been trying my whole career to avoid a bleb. But this does have a role in specific patients who maybe won't do as well and might not get the pressure lowering just from an angle procedure. Some of you know about PreserFlow, and that's a device that is similar and also done ab externo. And we don't have access to PreserFlow in the United States, so I only know the published data, but I would say similar findings to Zen. One of the biggest issues for me is the rate of needling after Zen placement. Very, very high, 40 to 50% within the first 3 months of implantation. So this is ECP. ECP, endocyclophotocoagulation. I am a huge fan of ECP. I like combining ECP with angle procedures. Inflow and outflow can be targeted by doing ECP and something in the angle. It's also one of my preferred pathways for treatment when the conjunctiva is very scarred. The trick is you have to do it the right way, as you're seeing in the video. So when I'm doing this, you see me painting the ciliary processes. I'm not just lasering each one, but I'm painting all of the ciliary processes with the laser. And what I'm aiming for is getting a contraction of the ciliary processes, a whitening of the ciliary processes, but not a popping of the ciliary processes. So think of ECP as a potential. It's expensive to buy the console and it's expensive to buy the probes, and that's one limitation. So let's get back to that patient case that we started out with. 65-year-old with primary open angle glaucoma, goal pressure of 15, and the pressure today is 18. No prior glaucoma surgery, and the patient is using latanoprost. And the visual field shows early nasal step that is progressing, as I said, very slowly. So I don't think it's surprising to see that my answer for this patient is typically goniotomy. Of course, combined with phacoemulsification in this patient who has a visually significant cataract. And the reasons are that it's safe, effective, and it exposes several collector channels with one treatment. Now, if I change the scenario to what you see here, where the patient had a prior glaucoma drainage device and is currently on maximal tolerated medical therapy, so very different than the initial scenario, and now their nasal step is said to be progressing rapidly. So in these patients, I would consider combining inflow, outflow, doing 360-degree ECP with an angle procedure. I'd much rather do that than putting in another glaucoma drainage device. You could consider doing light CPC, cyclophotocoagulation. If you don't have access to ECP, of course, CPC is a good alternative. Now let's change the scenario again slightly, and the goal pressure is now 10 instead of 15. No prior glaucoma surgery, but still on maximal tolerated medical therapy. And the patient has a steadily progressing nasal step defect. So in this case, we're back to where we started. This patient needs a trabeculectomy. It's hard to do glaucoma without still doing trabeculectomy and glaucoma drainage devices. And what I mean is there's still a role for the traditional filtration surgeries. We talk about the continuum, and several of my talks have discussed this continuum of drops, laser, surgery. But what MIGS procedures have done is really disrupt this algorithm of going from 1 to 2 to 3. We can now tailor our decisions to age, pressure, visual field status, and type of glaucoma. So where are we headed? I think we're headed to a more nuanced approach to glaucoma therapy. We have more choices, very similar to tailoring an intraocular lens for a specific patient. We have head-to-head data to compare different devices to each other. We have many companies that are selling these devices, and so they're training surgeons on how to use them, so we're getting better. We are learning a lot more about combining inflow and outflow, as well as potentially drug delivery, which is getting on the market slowly. In the United States and in other countries around the world, there's also a big struggle and discussions around reimbursement and making sure that the care is possible economically for the physician. We're also starting to see the same excitement that we were seeing for MIGS for drug delivery now, where drug delivery options are increasing with new companies coming to the market. The story of glaucoma really is a story of previously having no options or few options to now having many, many options. And I'm personally very excited for the options that are coming to the market in the next 5 years. We have some great things coming to the market. So great question. How much of the trabecular meshwork should we remove at the time of treatment? If you remove 3 to 4 clock hours of trabecular meshwork, you get the maximum benefit of the treatment. We found that going beyond that to 5 and 6 clock hours doesn't add much IOP lowering. So the positioning for MIGS surgery is to tilt the patient's head towards you 30 to 45 degrees. So you're pushing the patient's head away and you're tilting the microscope towards you 30 to 45 degrees. Typically 30 to 35 degrees is enough for both. The eye itself, you want to have the patient look slightly towards their nose, right? And then when you're in the eye and doing the procedure, you're partially holding the eye in place when you're in the eye with the device that's doing either the insertion or the goniotomy or the canaloplasty, whatever you might be doing. You don't want the patient looking towards you as the surgeon. That's the big thing that you have to watch out for. Two things that I'll mention is you can have special gonioscopy lenses that can hold the eye in place. They have extensions on the bottom. And there are also hands-free options for gonioscopy where you just put the lens on the eye and your second hand can hold the eye in place through a paracentesis. I don't think either are necessary. We get by without using either one of those.
So Dr. Kahook, this may be a pediatric glaucoma question, but it's from Dr. Singh. And it says, if the cornea is clear, do you prefer a goniotomy or a trabeculotomy? I think you're talking about when you're discussing goniotomies, that's more adult, but if you could discuss that, that'd be great. And have you ever used the KDB in children?
So this goes back to something that I said earlier, which is we don't treat what we don't see. So if the cornea is edematous, whether it's an adult or a kid, and you're doing gonioscopy and you can't see the angle, we don't do an ab interno procedure. So in a pediatric case, we would do the trabeculotomy, ab externo. In adult patients in the US, we don't do trabeculotomy. We would choose a different procedure. But there are countries that do trabeculotomy in adults, like Japan, for example, where they do that quite routinely. And then the next question about can KDB be used in pediatrics? Yes, it has been used in pediatric cases. The toughest thing, of course, about pediatric glaucoma is the anatomy is very different. So you have to be very experienced when you're doing gonioscopy to treat what is trabecular meshwork. But thank you for putting up with a couple of hours of lecture here. I really appreciate it.